Okay, let's go ahead and get started. As a few of you know, today's the second proposal defense. New track, although there's a few of us who managed to attend both of these talks. Anyways, today is Nathan Bahr's dissertation proposal defense, and the purpose of these sessions is for him to present his proposed work to us, and we comment on it, and then when we're done, we leave him to his committee, and they may have further questions and comments, and ultimately decide whether he's ready to go forward. So Nathan has been a fixture around here for a while. He got his master's degree here. Prior to that, he received a bachelor's degree in bioinformatics from UC Santa Cruz, but he's in the clinical informatics track now. And he will present his talk. For those of you who are actually, I guess it's mostly regulars here, but when you ask a question, push down on the button so it gets recorded, and we're also streaming this over the web. So it's all yours, Nathan.
So my topic is about measuring team cognition in a clinical activity system. One of the reasons I wanted to explore this topic is that when we implement complex technology like electronic health records or even change the process, there aren't that many good tools or instruments that can measure the impact on of that process on team behaviors or the implications that it has for clinical team performance. So I'll just wait a few seconds for the phone to dial in and for the suspense to build up. You know. Hey. Hello.
Hi, Blake. We have you on now.
Excellent. Thank you. Hello, Dr. Leslora. Okay, so moving on.
I'm excited to see this.
Is there a way to mute this? Can you please mute your side, Dr. Leslora? Okay. I believe it's muted. Thank you. So. Okay, I think we're good. So one of the things I would like to just define up front is what do I mean by cognition and team cognition? Cognition refers to an individual's capacity to perceive, understand, make decisions, and act upon their environment. Team cognition refers to the cognitive activities that occur at the team level. This is a bit of a general definition at this point, but I'll get into more detail of what that actually means. Suffice it to say, team cognition depends upon this phenomenon by which this theory that cognition can be externalized. That is, I can say or write something down from my own mental models, and then you can read and understand it and incorporate it into your own mental models. So one of the things I wanted to do first was to take a look at how teamwork or teams are typically assessed in the clinical environment. So just as a broad overview, I looked at a couple of systematic reviews of different studies measuring teamwork. In the surgical environment, checklists are used to coordinate activities. This is because a number of researchers have found that teamwork, in particular communication or lack thereof, has contributed to certain types of surgical errors such as wrong site operations. Now, these studies have typically been evaluated using instruments that assess the perception of teamwork, or by analyzing the the number of communications or the number of disruptions that occur in communication. Now, in terms of internal medicine, just as a general assessment, teamwork has been measured through a couple of different instruments. Many of them are either subjective assessments of teamwork, where people rate how good they feel teamwork is, usually before and after a training event. Hello. And a few of them assess skills in terms of communication skills. How often do they explain, the events that are going on during a surgery? How often do they perform closed feedback communication? And do they have the requisite knowledge to perform their task? And in the emergency medical setting, they evaluate teamwork by particularly looking at handover events, and they look at the quality and the content of information that the quality and the content of information that is transferred from one person to another. Now, one thing that I've observed through these articles is that there's a large number of instruments that are used a large number of instruments and a variety of techniques that are used to measure teamwork, but they also tend to depend on usually a similar set of techniques that are based on a subjective perception of teamwork rather than a direct measurement of the team's behaviors. So what I wanted to do was to use team cognition as a theoretical framework for organizing and developing different measures of teamwork and assessing their relationship with team performance. So as part of my main theoretical question, one of the things I want to ask is, okay, how can we measure team cognition in a clinical activity system? And I want to do this through two aims. One is to simply describe how cognition is distributed in an emergency medical service team as they're performing a number of tasks in a simulated environment. And the second is to measure the different properties of team cognition based on techniques that have based on constructs and techniques that have been identified by other researchers, and also to develop a couple of new techniques where necessary. So in terms of actually applying these different theories in terms of applying cognition as a theoretical perspective for measuring team behaviors, there are different theories that can actually describe cognition at the individual level and at the group level. At the individual, cognition has typically been used to describe human behavior or what goes on in the mind for individuals. And there are a couple prominent models. One of the most prominent models is the human information processing model, which describes a number of discrete and often measurable components such as situational awareness, memory, attention, decision-making that are part of the human decision-making process. And it treats the human mind or the human as an information processing unit, much like you would a computer. Another significant theory of human cognition is also naturalistic decision-making. It's this notion that humans do not necessarily make decisions in this linear processing method that you might see typically in a laboratory, but that they may behave differently in a naturalistic setting, particularly if you have a fireman reacting to a burning building. They're not going to, observe the event, go through all of their options, and then select which one's most appropriate, but they're going to react based on their past experiences and the affordances that their environment enables them to act. Now, moving on to Now, there are a number of theories that have attempted to extend cognition beyond the individual and to explain sort of what that actually means and the processes that actually occur. So, within individual cognition, there was this notion of situational awareness, or that an individual has a certain amount of knowledge about what's going on in their environment. This was developed by Micah Ensley in the early 1990s, and she extended this theory to apply to teams, namely that teams can share their situational awareness about a particular event to accomplish their tasks. What this means is that they can be mutually aware of their environment, and that this mutual awareness can enable them to coordinate or accomplish their own tasks specifically. Another theory of team cognition is also this notion of distributed cognition, which was developed by Edwin Hutchins. It's this notion that the cognition required to perform a task is distributed across the individuals and agents within a system. So, for example, suppose we are developing a map of OHSU and we both frequent different areas of the hospital. I might have a deep knowledge of what the BIC building looks like, but then someone who works, say, in the NICU might be able to draw that plan later. We can then combine those representations to make a more complete map of what OHSU looks like. Finally, there is a newer perspective that team cognition is formed up of both the mental models and team processes by which the individuals work together to achieve a common goal. This attempts to incorporate different behaviors such as communication and coordination into the development of shared mental models. So, in terms of actual representation, I've observed that there are two dominant analytical techniques or tools that are used to represent cognition. One of them is a propositional network, which attempts to model the semantic content of a group's mental models and model the overlap between them. So a propositional network is generated by interviewing your subjects, identifying key terms about the things they attend to in their tasks, and then finding the overlap between the subjects. Now, there's also another model that has typically been applied to different frameworks, such as the Human Information Processing model, and which is known as the decision ladder. And the decision ladder basically identifies the series of cognitive steps that a person or an individual goes through to make decisions about their task. And this occurs through roughly three main stages of obtaining situational awareness, trying to use past knowledge to make decisions and review options to make decisions about that situation, and then to try to move from an initial starting state to an end state, or a desired end state, and perform the action to achieve that. One thing I should mention is that decision ladders have been used in a team setting or different researchers have chained decision ladders together in a team setting to show how group decisions are linked together to perform a task in a coordinated manner. So one of the things I would like to do as part of my AIM 1 is describe how tasks or how emergency medical service tasks are distributed amongst its members. One of the reasons I want to look at emergency medical service teams is that they're relatively small, they perform well-defined tasks, and that these tasks occur over a short observable time frame, and also that they're co-located. This means that I can be present for a series of events and observe multiple events over a short period of time to collect some data. And it also represents a rich and complicated environment in which people are trying to make risky decisions in a short time frame. Another thing is that I'll also be looking at how these teams are performing their tasks in a series of simulations. So one of the reasons to look at simulations is you don't interfere with patient care, which is one good thing. And another reason is that we have more control over the environment to specify what the task is, perform repeated tasks so we don't actually have to wait for those events to occur, and so on. So in terms of actually observing these events, I am partnering with Dr. Gee and her team of emergency medical service for children staff. They are already set up to observe a series of emergency medical service teams across the state of Oregon, and they're planning to contact those people soon and ask them to perform a series of simulations. So Dr. Gee's team plans to observe about 40 EMS teams, which consist of 2 paramedics and about 3 to 4 firemen volunteer across the Multnomah County and across Oregon. These teams will participate in 4 simulations. 2 of these cases are related to trauma, and 2 of these cases are related to cardiac arrest. And they're attempting to manipulate different variables in these cases to evaluate the impact of different protocols and anxiety on team performance. So this has a couple of implications for my study. One is that as a pro, a lot of the data collection is set up for me, but as a con, I'm not able to test specific hypotheses due to the design of the study. But I think that the environment will still provide a rich enough set of data for me to explore applying different measures of team cognition. In each of these simulations, we plan to have the teams be dispatched to a setting, spend about 10 minutes responding to the case and treating the patient, 10 minutes to 10 minutes to travel to the scene, 10 minutes to treat the patient, 10 minutes to travel from the scene and transport the patient to an advanced care facility, and about 15 minutes for a debrief interview in which they will be investigating the different decisions that led up to particular errors. I believe the debrief interview will will analyze the critical decisions of the event that led up to certain errors, particularly the cues and the actions that occurred. Finally, the data will be collected through a number of different instruments, primarily a set of GoPro cameras, eye tracking glasses, which tracks both eye movement and the target scene at which the participants are viewing. The debrief interviews will be recorded through a recording device, and these events will be transcribed. So, and also, these events will be observed by subject matter experts who will score the team's performance along various criteria such as CPR management, airway management, number of errors, their clinical teamwork, and so on. So one of the ways in which I want to analyze this data is I want to organize the event. I want to use decision ladders as an analytical tool to demonstrate how the cognitive tasks are distributed between the different members within the team. So the decision ladder has a number of boxes to fill. This can be simplified, as I mentioned, into three basic components, which is situational awareness of the initial starting state, the analysis of the options for responding to that starting state, and the execution of the task to transition to a desired end state. Now, if we're dealing with experienced participants or subjects, they can actually just shunt their activities by immediately recognizing a scene and performing the desired action without considering the without actually thinking too hard on it or considering the different options and weighing them. So one of the things that I did in thinking about applying decision ladders is I looked over some previous videos of paramedics responding to a seizure code. And the reason I wanted to do this was to understand how well could decision ladders be applied to this particular setting. So one of the things I have here, you don't actually have to read it, is the Multnomah protocol for responding to a seizure case. One of the things to notice is that this is written out in a series of steps, and that it doesn't actually describe how the task should be distributed between the members in a team. So it's a normative description of how seizures should be handled, but in terms of the actual execution of those tasks, those are left up to the expertise of the paramedics. So when I was observing the paramedics responding to a mock seizure code, the paramedic would observe a seizing patient, and they would administer midazolam to treat that seizure. And while they were doing that, they were communicating with their cohort or their colleague, who was also observing the scene, and he requested that person administer oxygen. So in this case, that task was. This provides a brief example of how a brief simplified example of how that task was distributed across two members of a team. Now, I would like to apply this to the full set of simulations and the full set of teams to look at, to identify, patterns in behavior in terms of how they distribute their tasks and work in a coordinated manner. What I anticipate in terms of the outcome is a map of team behaviors in responding to these particular simulations. But more to the point, I want to use these descriptive models to provide context for the measurements that I'll be taking in Name 2. So as part of my second aim, what I want to do is specify the properties of team cognition. I'll do that in the next slide. Measure team cognition using previously developed metrics, and develop alternative metrics where necessary to measure some other properties of team cognition, and then to develop and validate a regression model of team cognition. So at a broad level, there are two types of metrics, or two classes of metrics that I've observed with regards to assessing team cognition. One is a knowledge-based approach, and one is an interaction-based approach. The knowledge-based approach tends to elicit the mental models of the subjects and either measure the degree to which the subjects are, to which they provide the similar answers, or to which they know one another's answers. So one of the earliest techniques of this was the Sagat approach developed by Micah Ensley, in which she developed situational requirements and probed individuals to ask them what they know about their environment. This technique has been extended to groups and has been applied for the most part retrospectively to ask participants what they knew about the environment as they were performing the task, and then they measure the agreement between those participants. This has also been used to measure mutual awareness between subjects in terms of what does one subject believe another subject knows in terms of what they were observing. The interaction approach attempts to measure different types or forms of communication as a representation of team cognition. For example, how many times have people communicated? Did they perform closed feedback communication? Were there any glitches or disruption in that communication? And what is the topological feature of that communication pattern? Or how does communication flow through the members of a group? Is it completely linear? Does it form a completely connected graph in that everyone talks to everyone? And then what does this mean in terms of performance? So in terms of specific properties that fall within these different categories, the different constructs I've identified are situational awareness, mutual awareness, interactions in terms of communication, coordination, workload, organizational structure, collective intelligence, and emotional intelligence. Shared awareness focuses on whether the participants know the same thing in the same way about their environment. That is, they agree that this apple is red or that it's a windy day. Now, mutual awareness is a particular construct in which people are attending to one another and they're aware of what another person is doing, but they may not necessarily be aware of what that person is attending to. Interactions can take the form of basic verbal communications of whether two people talk to one another. Coordination refers to whether people are sharing resources. Workload refers to, for the most part, how burdened people are by their particular task. Organizational structure refers to the topology or how people are arranged both physically and organizationally within an environment. So if you might have a hierarchy in which someone is a leader or a follower. And there are these two other factors, which I recently discovered from a paper in which Woolley et al. Identified this phenomenon known as collective intelligence. What she did is she applied a battery of intelligence tests to groups and identified a latent factor in which there was some latent factor for group intelligence that was actually distinct from individual intelligence. Finally, she found that emotional intelligence, as measured by the eyes test or individuals' abilities to perceive emotion by just looking at the eyes, was correlated with this notion of collective intelligence. So in terms of actual measurements, the constructs that I want to focus on are shared awareness, mutual awareness, interactions, coordination, and workload. So the way I plan to measure workload is to measure coordination in terms of the number of coordinated tasks or the number of times participants within a simulation share resources. So for example, if you have two paramedics that are both looking at an EKG machine to assess the patient's pulse and then they both act on their own individual tasks, then that represents a coordination of a shared resource. Now, communication has actually been measured in a variety of different ways. One way is to simply take the raw count of communication. Other ways have been to look at the need of communication or the rate of communication, which is the number of communications over time. Macmillan took two different approaches, which was to measure both the rate of communication and the efficiency of communication in terms of the ratio of pushes to pulls. So for example, if I'm sending information out or if I'm not requesting information, then that implies a certain level of efficiency in that I don't have to ask what's going on from the other person. Now, one of the things that I wanted to look at was different techniques for measuring team awareness. Now, team awareness has typically been measured by administering a series of probes about the task to a set of participants and asking what they know about the situation and measuring whether they agree. Now, the simulations that I plan to observe are occurring in quick succession, and it actually makes it a bit prohibitive to apply a complicated set of probes to assess their awareness. So And because I also have a set of glasses tracking their eye movement, I want to attempt to apply a different indirect measure of their shared situational awareness. Namely, I want to see if there's some notion of coordinated gaze fixations to see if they attend to the same environmental objects within the same time frame, to see if they're coordinating their activities about certain aspects of the task. Other measurements are other measurements that have been applied is also a mutual awareness, in which Macmillan looked at the percentage of agreement on other members' tasks. Now, the way I want to use this in terms of gaze fixations is to count the number of times participants look at each other and try to pay attention to one another's tasks. Now, this may need some tweaking because this only represents one channel of information, and the paramedics can attend to one another both visually and acoustically, so I may have to take that into account as well. As for workload, workload has typically been measured using the NASA TLX score. It's a set of 6 questions which are used to ask participants how difficult do they believe the work was, and how burdened do they feel by the work. And again, the constraints of the simulations make it difficult to administer a survey. But the glasses also provide an alternative measure of workload in the form of the index of cognitive activity. What that is the glasses actually measure the rapid dilation of rapid pupil dilation, and interprets that as brain activity, and that is a measure of cognitive load. Now, there are certain pros and cons to this. One nice thing is that we can measure cognitive load. Con of this is that we cannot necessarily associate that cognitive load with the particular task. That is, people could be thinking about their next birthday party or something like that. So the ways in which the ICA have been applied in terms of a team setting is people have taken the cumulative cognitive load as a measure of overall team workload. I would like to do that, but I would also like to try something else in terms of looking at the difference of cognitive load between the participants. And this would give me a measure of the equalness, or of the equalness of cognitive load between the participants. Namely, is one person taking on all of the tasks at any given time, or is the cognitive load more evenly distributed between the participants? And what implications does that have for performance? In terms of my outcome measures, I plan to look primarily at the clinical teamwork scale and number of errors. There are other measurements that are being taken as well in terms of time to deliver epinephrine, time to compressions, and the subject matter experts assessment of airway CPR, medication, and scene management. I want to focus on the clinical teamwork scale to see if the measurements are correlated with an expert's perception of what teamwork is, or of good or poor teamwork. And I want to use the number of errors to see if it's actually associated with performance. The reason I'm focusing on 2 measures is that if there are no errors and people are performing their tasks with a high degree of excellence, then I can fall back on the teamwork scale. The clinical teamwork scale was developed by Dr. Gee and her team, in which a subject matter expert answers a series of Likert scales scoring the participants on a number of different factors in terms of overall performance, communication, situational awareness, decision-making, and role responsibility. These different categories tend to be scored and assessed individually, but I have seen a couple of different papers just take the overall median of all of the scores combined. Finally, the particular constructs that I'm focusing on are shared awareness and mutual awareness, interactions in terms of communication, coordination, and workload. I plan to split the simulation data into a training and testing set, perform exploratory data analysis to identify the factors that are correlated with my outcomes metrics, and to develop a regression model and validate that regression model on the test set. So what I'm hoping to do is, from all of this work, is to develop a model of distributed cognition within EMS teams and a framework for describing teams according to their joint cognitive properties. I plan to accomplish this by delivering my proposal this month, my proposal defense this month, perform data collection over the next 7 or so months, perform data analysis in the following 2 months, and write my dissertation within 6 months after that. Finally, we've reached the end, and I would like to thank a number of people, including my advisory committee, Dr. Gorman, Dr. Agee, Dr. Lesaroth, Dr. Mohan, and Dr. Vukovic for providing me feedback, and for a number of DMICE faculty for also for helping me through this, including Diane and Andrea and Lynn for helping me through various logistics, and for various colleagues such as James for listening to me prattle on. Yes, and I would also like to thank the NLM for providing me funding to do this project. Thank you, and I will take questions now. Yes.
Of course. All these years, you'd think all right. The tracking glasses.
Yeah.
Those are going to be recording video of the scene that the wearer is wearing, and then also you'll be able to overlay a little point of what part of the scene they were looking at. So are you going to be automatically analyzing this data?
No. I am sadly going to be sitting in front of a computer screen and coding that data.
So that begs the question of how are you going to develop your coding schema, and do you know what you're looking for?
So in terms of the quantitative analysis, I just want to code into the physical object that they're looking at and the time frame that they're looking at. I don't think I'll need, so I think that in terms of the qualitative analysis, I will need some form of external validation, and I would like to ask some folks on the EMS team if they have time for that. I did not have plans for doing it for the quantitative analysis because it seemed pretty self-explanatory. They're looking at a chair. They're looking at a box. The gaze is focused on that. I see you have your eyebrows raised, so is that
I do, just because I can see that going off the rails quickly, and I think a lot would depend on the resolution that they get out of the goggles. If they're looking at this package of equipment versus the package of equipment 6 inches to the left, is it going to be able to distinguish that? That might not matter. So is there a way you can pilot test that?
I think we have looked at it in a private setting, and it actually looks to be fairly accurate.
Cool.
So, yeah. Anyone else? Yes.
Thank you. Nice presentation.
Thank you.
The question is, what's going to be your role during the simulation? You've got a distributed team that's coming together for an emergency.
So my role is to hopefully stay out of the way and take observational notes.
But where are you going to be? Are you going to be
My
with a particular team member? Or?
So I plan to be there in attendance, and I plan to observe. A lot of the data collection will occur without my. A lot of the video data collection will occur without me. So, but I will be analyzing that data collection afterwards. There will be subject matter experts who will be performing the debrief interview. I think that this is actually appropriate, as they'll be able to focus in on the particular elements of the simulation where they're not proceeding according to standard practice or not. So,
Thank you.
Dion.
This is not a, first of all, very, very interesting topic. So, some of the stuff I've read, though, particularly in the aviation
Yeah.
environment,
That's actually a lot of where I'm drawing my
right, I recognize some of
stuff
the articles.
from too.
But they rely heavily on oral, meaning, sound cues.
Mm-hmm.
How are you tracking those and bringing them into your analysis?
That's actually a good question that I haven't thought about yet. And that one, I think that if I were tracking oral cues, it would happen primarily when attempting to measure different forms of situational awareness. And I'll have to look at the data to see whether I can or cannot incorporate that, because I think if I'm observing someone performing a task and they hear something, there may be no obvious evidence that they've heard something or that I can, see that they've actually heard it. I mean, I can do that with the tracking glasses. I can say that a sound occurred in the environment. I may be able to infer that they heard it by their subsequent set of actions, but I won't. But if they don't sort of exhibit any outward change in behavior, I won't necessarily know if they heard those cues. So I'm not sure yet whether or not I want to incorporate them within the scope of my analysis, and that may just be a limitation in my approach to the problem. So, yes?
Did I understand that part of this would be recorded and transcribed? So would you actually have a transcription of the entire process or just of the interviews afterwards?
So I believe the interviews are being transcribed. I'll have to.
Yeah, we're thinking that the debriefs will be transcribed, but not the whole, but Vicky could, he's got the audio, so he's got the method. That might help with the other issue.
Yeah. Well, even then, I'm not sure how well that would help, because I would still identify that someone emitted a verbal or audio cue, but I still won't be able to identify whether it was heard. And I think that's kind of a tricky thing to measure. Yes?
So you have GoPros. Would you be having those, for example, to be on the ambulance driver en route to the scene?
Yeah.
And so you would be able to record the communications that are occurring en route.
Yeah. Yeah. I think that's the reason they're there.
So we can see the activity in the back of the ambulance before we begin the
Hi. Would you clarify your thinking or expand on your thinking a little bit for the focus on errors as the key indicator or the key method by which you assess cognition of the team? I don't quite follow why that would be, and maybe you didn't mean to suggest that you would only be.
So I think, well, I did say that I was primarily focusing on errors, because I think that errors tend to be sort of a standard metric used in healthcare because people want to reduce errors. And one of the reasons is because, glitches or particular configurations in team communication or team interaction may result in errors in which an individual has a mental model that is not necessarily consistent with what's going on in the environment. There's actually a contrast. So I think one of the reasons I wanted to look at errors is that errors represent a particular deviation in behavior that will be able to describe and observe and identify the root cause of. And I think that if we identify the root cause and see if it's associated or not with team interactions, that would be informative of some aspect of team cognition.
Right. So I guess I would just suggest that in the sense that you want to establish a more general kind of theoretical framework, which you indicated, that you might want to give thought to more broadly
So
looking beyond simple errors as the measure of,
that is true.
of cognition.
Well, I think that's also, I think it's a bit tricky coming up with a generalized performance metric for a particular task, because any performance metric will naturally be molded to the task. I think in terms of having a generalized score of performance, the clinical teamwork scale most closely approximates that, because it is an expert's assessment of whether the team performed well or whether they did not. So I think that in the event that errors may not be more informative, I think a subject matter's expert assessment on whether the team performed well in their simulation may actually be more informative. Yes?
Just two comments really quickly. One of which, it sounds like you're going to have videotapes
Yes.
of the teams. And that one possibility for you is to go in and annotate the videotapes as well.
Mm-hmm. Yeah, I was actually planning to do that.
Okay, and have you an idea how long it takes to do that?
Yeah, I actually do. That paramedic video I was annotating took me about 2 hours to annotate, 10 minutes. So.
Yes. So So what you.
But actually, I was transcribing that video, not simply annotating it. So.
One suggestion for you is you might want to take, because you're going to have a large number.
Yeah.
Do a propulsive sampling of the
videos,
and then say, so what differentiates
okay,
a high-performing team versus a poor-performing team as measured in the scores?
mm-hmm.
Okay. The other suggestion I have is that you might consider, in addition to the teamwork score, which actually to me looks like it's behaviorally based, like do we have, you talked about communication behaviors and
Yeah.
a lot of, I would almost call the underpinnings.
Yeah.
But the question is, do we get the guy to the hospital within 3 minutes, or did it take us an hour? You might
Okay.
want to try and look at
So-
that type of thing too. And maybe there is a point at which...
That may actually be kind of tricky, because I think that, I mean, it sounds promising, but in some respects, the events may occur within a fixed time frame, meaning, okay, you do CPR for 2 minutes as part of protocol, and if that doesn't work, like, get them to the hospital as fast as
Okay,
you
but your metrics could be, for example, how long does it take you to get the defibrillator to the scene?
Uh-huh. There was one up there,
How
so
long
for
does it-
time to epinephrine.
Yeah, so it's how, time to epinephrine. How long does it take for you to complete the initial assessment? How long, So it's that type of thing that can be destroyed by bad teamwork.
Mm.
And so my just suggestion is you might want to work with Dr. Gorman and Dr. Geese to try and see if you can come up with some
Behaviorally driven metric of performance.
more like, what's the box score, and then we can look at what the RBI was or whatever it was in below it.
Okay. That's actually a really good idea. Thank you. Okay. Yes.
I had a question regarding the role, and was wondering if your teams will have like a team leader, or if all the team members will be like equal members of the team.
So
Because that could affect like who they look at and who.
I don't think the roles are assigned a priori, but that they may occur naturally as a product of that team having worked before, or maybe even spontaneously, just because one person's more inclined to take a leadership role. I think that's an interesting question, because that may actually show up in terms of the descriptive models. Is how does someone take leadership, and then how does that manifest in terms of their delegation of tasks to their partners? And what happens when they're attempting to take a leadership role with someone they don't know? Is there some kind of conflict glitch or not? I think that it'll be an interesting thing to observe and see how it emerges, but that the roles are not assigned a priori and that they're going to occur naturally. Okay.
Yes, again, really good presentation, really interesting topic. I was wondering, there you go. I was wondering how this relates to ATLS training training, because from my experience, from doing those type of training and working under those type of protocols, you have assigned positions in the team. Like there is a leader, there's another. So positions are quite fixed. I mean, things cannot happen outside what the protocol dictates. If you do that, you're not doing PALS, you're not doing ATLS, you're doing something else. So it's very strict what you're supposed to do. I don't know how that relates to this type of...
I would argue yes and no. So that's how, first, that's how the folks are trained. But second, I think that's how they're trained in light of a pre-structured event that is supposed to occur. But the teams may behave differently when they're confronted with an event they're not familiar with. So if there's a certain amount of uncertainty and a limited time frame, they may behave in a different manner.
Yes, but in the simulation, that's not supposed to happen. You're entering the simulation where you... In ATLS, again, I don't know this, but in ATLS, you say, these are your positions, you're assigned your positions, you go inside, you might not know what you're going to face, but you know what your role is. And you know
so let me ask you a question. When you're doing that ACLS training, what is the setting? Are you doing it in a hospital?
In my case, yes, but I know they do it in schools also.
So the distinction between that and the cases we're working with is that we're actually setting up different sites that people travel to. So there may be certain constraints of the environment that determine how the paramedics and the firemen behave. And that may alter their behavior, or they may act in a very structured and predetermined way. If that happens, then I think what the evidence will show is that there's no difference across teams. And I think that would be very interesting also. So I think it would probably not bode well for my attempt to measure and assess differences across teams, but it may be interesting to see the impact teams have on the impact certain training has on normalizing behavior to a very rigid extent.
And also the last thing, do you know if they are tested on this?
So yeah, we're working with professionals who are active paramedics and firemen.
They have to perform in a certain way. Okay.
So they're experienced. Yes.
Do you plan on gaining any domain knowledge in basic or advanced life support? And
yes.
If so, if yes or no, how do you anticipate your knowledge to impact your interpretation of the results?
You're a tricky one. So I'm going to... So the way I was planning on doing it was I was going to pick up a couple of books and attend and observe the courses to see how the folks are trained. What I anticipate is that this would give me a normative model of how they should behave, and this would allow me to contrast it with how they actually behave in the wild. So I'm mostly looking for differences between how I think they should behave and how I actually observe they behave. So, anyone else? Yes.
Just another question. So one of the issues you could potentially face is that there are significant differences in the training given to different EMS people. Like Seattle, for example, has a pretty rigorous 2-year course, and you come out of it, you're making $140,000 a year.
Yeah.
Versus other places, it's much, much less rigorous.
Okay.
So how are you going to account for that?
So I'm... Yes. Okay.
So actually in Portland, we're lucky. All of the people that respond are paramedics, so they all have a level of training at the highest possible level of paramedic. So the only part that would vary in this case would be the amount of experience they have. The good side of that is that we are doing pediatric emergencies, which are so rare that even the most experienced person doesn't have a ton of experience, which is why we're doing this study and looking at errors and safety and teamwork and things like that, because while they could do ACLS in their sleep and they can resuscitate adults, what we're finding is their ability to apply that. It isn't good to take adult and then apply it to kids.
Yes.
And then there's kids that are babies and kids that are elementary, and then there's kids that are getting closer to adult. And so that variation also is something where there are decision points in their mind, and that's why this becomes so important, is because it's not quite as clear. They are having to make decisions first on which path do they go, what do I have in front of me, and where do I go? And they're all trying to do that for something that they don't see very often.
Okay, but I think I just heard from you is that you're pulling from one pool, you're pulling from the Portland as opposed to pulling from Portland and Lane County, which are extremely different.
Multnomah County. So we're doing all of Multnomah County, and there's a structure. They all have paramedics.
Okay, sounds good. Well, thank you.
Thank you.
And we'll